Hello everyone, and welcome to A Healthy Dose, a podcast serving you current events and medicine. On today's episode, we're reviewing chronic kidney disease and acute kidney injury through the lens of farmers across India who have suddenly been affected by these diseases. Some farmers who previously led healthy lives now suffer from CKD and rely on dialysis for survival. Today, we have Swar and Sid, both afflicted by this epidemic, to share their stories and to help us dive deeper into kidney disease. Let's begin the episode with the pathophysiology of chronic kidney disease, or CKD, and acute kidney injury, or AKI. The causes of CKD can be classified as pre-renal, as found in atherosclerosis, intrinsically renal, as found in diabetic nephropathy, and post-renal, found in BPH. Diabetes and hypertension are, by a large margin, the most common causes of CKD. But regardless of how it starts, once half of the total nephrons are affected, then CKD will pretty much progress all the same. The underlying condition involves an insufficient amount of nephrons. This causes permeability in the glomerulus to increase, leading to more proteins being filtered, which get lost in the urine. RAS then gets activated, and cytokines get released. GFR can actually increase during this time as a compensatory mechanism to the hyperfiltration. All of that can increase pressure in the capillaries inside the glomerulus, known as glomerular hypertension. That increase in pressure, accompanied by inflammatory mediators, cause more damage to the remaining healthy nephrons and accelerates sclerosis, which triggers a positive feedback loop and thus the progression of CKD. Small recap for taglines. Less number of nephrons equals activated mediators, cytokines, and RAS equals structural and functional changes of the surviving nephrons, leads to hyperfiltration and increased capillary pressure, equals accelerated sclerosis of the remaining healthy nephrons, thus reducing the number of nephrons, and the cycle starts all over again. CKD can lead to a few complications. Anemia due to decreased EPO production, hyperparathyroidism due to less excretion of phosphates through the urine, keeping it high in the blood, which leads to an increase in PTH. And of course, if it wasn't already an issue, hypertension due to the retention of sodium and fluid, the increase in RAS activity, and an increase in the sympathetic nervous system activity. I'll pass the mic over to Sydney to explain the pathophys of AKI.
Before I start on the pathophysiology of acute kidney injury, or AKI, I thought I would review what an AKI is. It is an abrupt decrease in renal function. As a provider, you will see your patient's GFR decrease, blood waste products increase, known as azotemia, and an improper regulation of volume, electrolytes, and pH. AKI is a syndrome. It has a plethora of causes, including but not limited to hypovolemia, low cardiac output, and changes in vascular resistance. This syndrome was previously called acute renal failure or insufficiency, but now we just call it AKI. Okay, now to move on to the pathophysiology of AKI, I am specifically going to focus more broadly on ischemic acute kidney injury. This is caused by a lack of nutrients and oxygen being delivered to kidney cells and very little waste products being removed. As a result, tubular epithelial cells are injured, and this leads to apoptosis and necrosis of the cells. Necrosis is what allows us to see casts in the urine. There are many disease states and medications that can lead to ischemic AKI. Interestingly, when the endothelium is injured in AKI, arterioles, which are the smallest arteries of the body in the kidney, are more likely to vasoconstrict than in a normal healthy kidney. This is because the injured kidney produces more angiotensin II, which is a potent vasoconstrictor. Increased vasoconstriction leads to decreased blood flow to the outer portion of the kidney, leading to further ischemia. Think of AKI like a domino effect. Once the kidneys are hypoperfused, there is continued cell death. Inflammation and the innate and adaptive immune system also play a huge role in AKI. The innate response is early to the scene, while the adaptive immune system is the witness that comes forward with a statement in a few hours after the crime. The tubular epithelial cells are not only the victim, but also produce a pro-inflammatory state within the kidney. Inflammation further exacerbates AKI. There's also an upregulation of certain genes within the proximal and distal tubules, which can be found in the urine and used as a non-invasive biomarker of AKI. These genes include KIM1 and NGAL. As you can see, the pathophysiology of AKI is complicated, and as always, there's more research to be done so that we can provide targeted therapy for patients. Next, Tasia will be reviewing the risk factors for developing AKI.
The risk factors of chronic kidney disease include diabetes mellitus and hypertension, which are also the two most common causes. Other risk factors include family history, gender. It's more common in women than men. However, men have a higher instance of being on dialysis. Additionally, there is a higher incidence in Black people. Risk increases with age, obesity, smoking, and low economic status. AKI is also a risk factor for chronic kidney disease. That brings me to the risk factors for acute kidney injury, which include increase in age and Black race, just like chronic kidney disease. Pre-existing kidney disease, such as chronic kidney disease, is also a risk factor for AKI. Other risk factors include cancer, anemia, critical illnesses such as shock or sepsis, cardiovascular surgery, nephrotoxic agents such as NSAIDs, ACE or ARBs, erythromycin, contrast, and aminoglycosides. Chronic conditions like heart failure, liver disease, and diabetes mellitus may also cause AKI. Also, anything that results in the patient being dehydrated or being unable to maintain fluid intake, low perfusion to kidneys, and or blockage of urine outflow can result in AKI. Now I will discuss some statistics of both disease states. A 2017 study reported 698 million cases of chronic kidney disease worldwide and 37 million in the United States, which makes it one of the leading causes of mortality. The mortality rate increased by 41% between 1990 and 2017. Unfortunately, the mortality rate is expected to get worse. It is expected to be the fifth highest cause of years of life lost by 2040. A U.S. study of over 3 million people found acute kidney injury to be most common among the elderly, males, and Black patients. Out of all the hospitalized patients, 1 in 5 adults have acute kidney injury, and respectively, 1 out of 3 children have acute kidney injury. The percentage of ICU patients with AKI ranges from 20 to 50%. Additionally, 30% of ICU patients with acute kidney injury also have chronic kidney disease. In order for these staggering numbers to decline, it is important we know the signs and symptoms of both disease states. That brings us to our guest, Swara, who currently has AKI, to discuss with us how it has impacted her life.
Hi guys, thanks for having me. My name is Swara and I'm the daughter of one of the farmers that's been affected with this awful disease. I wanted to share a little bit about my story because I actually have AKI and my father has CKD, and other people around us have some different symptoms. My symptoms have actually been directly related to diminished kidney function, so I've been experiencing some swelling, which I've been told is called edema, hypertension, and I've been urinating less, which I've also been told is called oliguria. Some of my friends with AKI have not been urinating at all, and others have some rashes on their skin. One of my friends actually has a rash, fever, and joint pain, which we found out was due to acute interstitial nephritis from an infection. But generally, I've noticed that people can have no symptoms too, so it really varies. My father, with a history of diabetes, who has CKD, had really vague symptoms until it became severe. He was generally really tired, but also had similar symptoms to me with diminished kidney function, including itchiness, hypertension, edema, and shortness of breath. My father also had some white things on his skin, which the PA said was uremic frost. Some of his friends with CKD have had restless leg syndrome and peripheral neuropathy, but those individuals were in the later stage of CKD. Luckily, some of my friends with AKI have been able to reverse their symptoms, but my father and other people with CKD were unfortunately not able to reverse them. So that, I think, is generally the clinical presentation that I've noticed with myself and the people around me with AKI and CKD. Since many people are also asymptomatic with AKI or CKD, there are labs and diagnostics that can be helpful for diagnosing, which Gabby will now talk about.
Thanks, Swara, for sharing your family's experience. Hopefully this information will help patients be more involved and aware of their health. So, in order to diagnose an AKI, you first have to stage it. The KDIGO guidelines are based on creatinine and urine output, And an AKI is present if there's an increase in creatinine of 0.3 in 48 hours or a 1.5 to 2 times increase. Stage 2 would be a 2 to 2.9 increase of creatinine and 3 times increase for stage 3. Stage 3 can also be diagnosed if the patient's creatinine is greater than 4 or if that patient needs dialysis. For urine output, staging is defined by oliguria, which is less than 0.5 milliliters of urine per kilogram of the patient per hour. Stage 1 would be oliguria for 6 to 12 hours, 2 greater than 12 hours, and 3 would be greater than 24 hours or no urine production for greater than 12 hours. After you stage the AKI, you want to find out the origin. So there's 3 categories: pre-renal, intrinsic, and post-renal. So pre-renal AKIs, you'll see a BUN to creatinine ratio of greater than 20 to 1, concentrated urine, and a less than 1% for fractional excretion of sodium. And this is because the body's holding on to all that sodium and water to increase perfusion to your kidneys. In post-renal AKIs, imaging is going to be your BFF. You'll want to get an abdominal and bladder ultrasound to determine if there's an issue in the bladder, ureters, urethra, or even the prostate in men. If the ultrasound is not diagnostic, you can order other modes of imaging like CT or MI. And then to diagnose the post-renal AKI, other than these imaging modalities, you can use a bladder catheter to see if urine is trapped, and it could be therapeutic for the patient as well as diagnostic. And the urine's not going to have any specific findings normally. Intrinsic AKIs are split into 3 different types. So acute tubular necrosis, you will have a low specific gravity in the urine and a fractional excretion of sodium greater than 2%, as well as muddy brown cast in the urine, which is pathognomonic for ATN. Acute interstitial nephritis will have large pale kidneys on the ultrasound and white blood cell casts and eosinophiliuria. This is because AIN is an allergic response of the kidneys. Lastly, for acute glomerulonephritis, you will have hematuria, proteinuria, and red blood cell casts, which are pathognomonic for the glomerulonephritis. However, most of the time you will need a renal biopsy to definitively diagnose this. So moving on to chronic kidney disease, there are 2 criteria that you have to meet: either a structural or functional abnormality or a glomerular filtration rate of less than 60, and this has to go on for more than 3 months. CKD is divided into 6 stages based upon your GFR. So stage 1 would be a GFR greater than 90, 2 a GFR that's 60 to 89, 3A GFR of 45 to 59, 3B 30 to 44, stage 4 GFR of 15 to 29, and 5 is less than 15. 5 is also called end-stage renal disease, and a patient automatically qualifies for this if they need a kidney transplant or dialysis. And then we can also stage CKD based on albuminuria. So we have A1 of less than 30 milliliters a day, normally to mildly increased. A2, which would be 30 to 300 or moderately increased, and A3 greater than 300. So for an example, you could document that a patient has stage G3/A2 chronic kidney disease. A renal ultrasound is also normally done in the workup if CKD is on your differential. A classic finding would be bilaterally small kidneys. However, there are 4 disease processes that could cause enlarged kidneys. And a good mnemonic for that is David parked Amy's Honda in Vegas. Diabetes, polycystic kidney disease, amyloidosis, and HIV. Next, for the urinalysis, you'll have proteinuria and broad waxy casts on your microscopy for CKD. And that is it for labs and diagnostics. So I'm going to hand it over to Sid to discuss the treatment and patient education aspect.
As CKD of unknown etiology plagues the state of Andhra Pradesh, we're going to take a turn to talk about the treatments and education of acute kidney injury as well as CKD. When it comes to AKI, we want to treat the underlying cause to prevent further injury to the kidneys.
We begin with fluid balance by combating volume overload with loop diuretics such as furosemide or torsemide, or by starting dialysis. We can combat hypovolemia by supplying isotonic fluids like normal saline. Furosemide and dialysis can also be used to treat hyperkalemia, as well as calcium gluconate or insulin to drive potassium back into the cells. Eating a low potassium, low sodium diet such as cauliflower, apples, fish, peppers, and beans can also help your kidneys recover. Dialysis is used as a last resort as it is the most invasive. Some of the villagers of Andhra Pradesh have been undergoing weekly dialysis treatments to aid in their diagnoses of CKD, as they didn't become symptomatic until it was too late. However, medical management of CKD is similar to AKI in the sense of treating the underlying cause and slowing progression of the damage. As hypertension is generally present, treating with either loop diuretics or thiazide diuretics can help slow the progression. Though contraindicated in AKI, ACE inhibitors or ARBs are generally the most effective in treating proteinuria. Treating proteinuria can also be achieved through SGLT2 inhibitors such as dapagliflozin and empagliflozin, as these are generally diabetes medications but can be given in CKD with or without the presence of diabetes. In the presence of cardiovascular disease with CKD, statins such as atorvastatin can reduce vessel inflammation. Sodium bicarbonate can treat metabolic alkalosis, and taking an iron supplement can help in the presence of induced anemia. The biggest piece of patient education is to have regular blood work screenings to be aware of your levels, ensure that your blood pressure is in a healthy range of 120/80 or below, have regular blood glucose and hemoglobin A1C screenings to monitor or uncover a possible diabetes diagnosis. Another major education piece is to avoid nephrotoxic agents. NSAIDs, ACE inhibitors, ARBs, metformin, and contrast dyes used in imaging are all damaging to the kidneys. Last but certainly not least are lifestyle modifications. A renal-friendly diet that is low in sodium and potassium, at least 30 minutes of exercise daily, tobacco cessation if you are a smoker, and staying up to date on all vaccinations indicated for your age group.
I first want to thank Swara for joining today's podcast and sharing her story. And thank you to Sydney for reporting from the village in India and educating us on management. Thank you both so much for joining us. And to all you listeners, thank you guys for joining today's episode number 104, Kidney Disease. And don't forget to like, comment, and subscribe to our podcast. A healthy dose of information every week, just for you. Don't forget to be kind to your mind, and we'll see you next time.